So next talk I want to share with you is basically 25 years of working in arthroscopy, and I think I gave this to Noam when he was, I think it was probably 15 years or something like that when he was with me. And so just some lessons to be gained. So one is be open-minded virtually all the time in the operating room. I actually highly suggest as a surgeon or as a practitioner, you visit a buddy's operating room or a buddy's physical therapy school. Because just like Ben said, the fresh eyes, you're going to have somebody else see things differently and you're going to learn something from them. An ounce of prevention is worth a pound of cure. Bottom line is one thing that I learned is the best way for my best outcomes for all of my surgical arthroscopic procedures is to never be there in the first place. And so ACLprevent.com, I screen all my athletes with single leg squats on stable and unstable surfaces. The FIFA 11 Plus programs for injury prevention for young throwers, pitch counts, as well as checking the environment of their play before they play to make sure that it's safe. So bottom line is avoiding the injury in the first place keeps me from doing surgery for better outcomes. Next thing is a lesson that I learned from one of my mentors called, that he said, proper pre-op planning prevents pitiful poor post-op performance. And the bottom line is these P's, if you think about this, is just be ready for everything. So a complete history and physical examination should occur before every single case and with every case. It should include a series of assessment of prior injuries, prior surgeries, history of hemophilia. I've unfortunately had people who've come referred from somebody else because they started to do an ACL reconstruction and they just couldn't stop the bleeding during the case. And they actually had a family history of hemophilia, but it had never been screened before. History of blood clots, particularly in female athletes on oral contraceptives to avoid the catastrophic complication of a DVT or worse yet, a PE in those athletes. Another thing that I think is really important with this is asking the athlete on the history examination, is there a problem of pain or is there a problem of instability? So a variety of my athletes who have ACL injuries, but their number one complaint is pain, their outcomes are going to be poorer because I'm not addressing their problem, which was pain, rather than instability or vice versa. In terms of you have to do a complete physical examination every time. So for your knee and ankles, you must include a careful hip examination and back examination. Ben just showed us one of the common things is people missed hip diagnoses because they didn't look for other things. We certainly have to do that. For me, in terms of all of my knee issues, you need to assess the total alignment. You need to have full range of motion as best as possible. For most of my ACL surgeries, my shoulder surgeries, I want full range of motion before surgery. Why? If I don't have it before, I'm probably only going to make them stiff and they're not going to do well after. So I delay many of my ACL injuries until I get full range of motion compared to a few of my colleagues at the bottom of a ski slope on a mountain who said, you tore your ACL, I'm going to fix you right away. I'm still worried about potential stiffness. You want to look for the associated injuries around the knee. That's going to be MCL, PCL, posterior lateral corner. One of my, when I started looking at doing my own fellowship many years ago, my mentor had to go in to examine a patient because she was busy seeing somebody else. And I went and examined the patient. I pulled backward and forwards on the knee, and I had a big anterior posterior translation. I walked out of that room, strut my stuff, saying, tore his ACL. She says, go back in and read, because I forgot to do a posterior drawer. Necessity actually had a posterior drawer. At that point, I knew I needed to do a fellowship, and she told me, don't be cocky, be complete. So you want to also do a relaxed examination. So when you do an examination of the knee and the shoulder, getting the patient to be as relaxed as possible is going to be the best way to assess their instability. Including the 8 Ps that we just talked about, good imaging preoperatively, and looking for all different types of associated injuries, whether it's avulsion injuries, patella alta, patellar tendinosis, patellar tendinopathy. Big problem to say I'm going to do an ACL reconstruction and use that as my patellar tendon graft. And so it's very common that I would sit back and go look and go, here I have a partial injury to the ACL, there's something there, I don't know if that's injured. I focused on the wrong thing and I missed the associated things in that picture. You want to look for potential repairable menisci. Patients don't like, and you want to assess this on the imaging before. I will tell you, a lot of my patients, historically, I will protect my meniscus repairs post-operatively for 4 to 6 weeks. Maybe on crutches, but they're all protected. And if I didn't tell them that before, because I don't do the same thing with my ACL reconstructions, they're unhappy with me. So preoperative planning, including imaging, so I see that, is very helpful for patient satisfaction. The 9th P of all these things is patient selection. You want to pick your patients very carefully. Will they do the rehab? In fact, I will tell them, and I think the last instruction here, I will tell them before, is if they're not willing to do the rehab, I'm not sure if I'm willing to do the surgery. They have to be committed to that. Are they freedom challenged? Are they able to do the rehab or get to physical therapy? Maybe they're copers, or there's somebody who doesn't necessarily require the surgery. All of those things are going to help affect your outcome. The other thing for me is, do they truly have informed consent? Many of my patients will come to me and say, Doc, fix me. I don't know what's going on, just fix it. And unfortunately, with those patients, if you didn't talk to them about the potential of stiffness, the potential of pain, the potential of recurrent instability, the potential of infection, and those things happen, they blame it on you. On the other hand, if you give them a good informed consent, they understand those risks and benefits going into it, then they actually, even if they have a complication, they're more willing to overcome it. The other suggestion is that my orthopedic colleagues here, hamstring guy, hamstrings, BTB, allogram, quad tendon. There you go. So the thing is that I think many of our stories, when we talk to patients about our graft choices before ACL surgeries, they sit back and go, well, how do you want to do it? I'm going to do a quad tendon. I walk through my story with them, and I tell them the pros and cons of each of those different choices. BTB, hamstring, donated tissue, allograft. Now, I also tell them my favorite is BTB, and I tell them that because even I walk through this as unbiased and evidence-based as I can, I have a little bias. So I tell them this is what I do the most of. And in some ways, what? The $20. Well, that's number 20 of my lessons. More prevention. Sign your site. I actually have wrapped the opposite leg on every case I've ever done in lower extremity to try to prevent doing surgery on the wrong leg. Talk to your patients preoperatively. Don't let somebody else do it. And actually perform a timeout to double check. Exam under anesthesia. Absolutely everything perioperatively. Clock going. Somebody has to add a clock to run me for safety time. So do an exam under anesthesia. Always compare to the opposite side. Safe portals. Walking through these, one of the things in terms of the approaching things arthroscopically is if you don't know how to get there safely, you have potential risks. We know, Ben probably knows, that come back over here doing posterior hip arthroscopies, sciatic nerve is in this zone. Tom Burns actually suggested rotating the hip into a neutral position to try to avoid that. But being aware that it's there. Or when you do an ankle arthroscopy, on the medial aspect of the ankle, that's where the neurovascular bundle is. We need to know where those things are and try to do things safely. When you do arthroscopy, you want to do it sequentially, the same way every time. Now I can tell you that your way may be different than my way, and the sequence that I have written down here may not be exactly the same as the other orthopedic doctors in the room. However, if you do it the same way every time, and for me, when I do a diagnostic knee scope, I always look in the lateral gutter before I go medially. Why? Because I'll forget to do it later when I find whatever's exciting inside the knee. So you want to do the same thing every time. You want to don't invent things on the fly. We just had a visiting surgeon come to the University of Illinois, and he suggested that one thing that he found when he was doing tendon repairs in the hand was he put the sutures in it. Sometimes it wasn't the great, so he put super glue on top of it. Was that written anywhere? Is that tested anywhere? No, he just kind of invented that on the fly. I didn't think that was a very good idea. Doing intra-articular pain pumps. Actually, they weren't necessarily proven. We know that they have a potential chondrolysis, but some people decided they were going to use a pain pump from somewhere else and put it into the joint, and the companies supported it. Problematic. Or using non-approved devices for the wrong purposes. People promoted the use of these plugs for cartilage restoration, and they haven't really been proven. Ultimately, surgically, always reproduce anatomy. That's going to be the ultimate key. You've seen Ben suggest repairing the labrum, how he put the sutures in to repair it, to recreate that suction edge. That's going to be true for everything we do, because we know that if you start doing things that are not anatomic, like a Clancy biceps tenodesis for posterior lateral corner reconstruction, repairing sublingual holes arthroscopically, all of those get stiff, or all of those have other problems. So the ultimate answer is surgically go back anatomically as best as possible. Outcomes never lie. Adjust as needed. This is actually, I actually was going to redesign how I did my tibial tunnels on the ACL reconstructions. And I do them a little bit more vertical than most people. And I do that because I get a smaller aperture in my tibia. I've got reasons for all this. The problem is that when I have a more vertical tibial tunnel, which gives me a round aperture here, my flood tends to be more back into cancellous bone. And I learned over time that my outcomes, actually they got a little stretchy a little bit at times, and it was because I needed a bonus fixation at the bottom. Without the bonus fixation, I only had cancellous fixation. So I learned, ultimately, pay attention to your outcomes and adjust as needed. Less may be more. Sometimes these degenerative meniscus, just because we see them on an MRI scan, they don't need to be treated. We know now from outcome studies that doing meniscus debridement on arthritic knees, not such a significant outcome. Optimized visualization arthroscopically, you have to be able to see what you're targeting. What I'm showing right here on these pictures is this is a little bump called resonance ridge. Arthroscopically, if you actually try to say, if you look at that and if you mistake that as being the over the back position, your femoral tunnel and your ACL will be too far anterior, they're going to get stiff. So you have a failed ACL. You want to recognize normal variants, such as the intermeniscal ligament, discoid meniscus, sublingual holes. Why? Because if you fix this, they get stiff. If you think this is a bucket handle meniscus tear, then you've done surgery on somebody who's wrong. So you want to look for all of those normal variants. Ultimately, at the time of surgery, always have a salvage. So if there's a problem that occurs, always have a backup. One of the scariest things happened to me was one of my residents a few years ago gave me a call in the operating room. He says, Dr. Hutchinson, I got a problem. I did an ACL reconstruction, I was pulling on the graft, and the whole thing came right back at me because it wasn't fixed. When he put a screw in, he peeled things off. Now, I don't really have a problem. I've had other complications myself. The problem was that he was calling me while he was in the operating room, and he didn't know how to get out of trouble. So I had to teach him how to do that. So at the time of surgery, always have the salvage, always have the backup. Patients judge you by your scars, so the smaller scars, the better. Be open to change. And so I think we saw Ben share a few different things about how he's modified things over the years. And certainly we know better materials and implants, from metal to bio to peak anchors, better techniques have all improved. At one point, the biggest shoulder surgeon in the world said arthroscopy was the tool of the devil. Well, we've learned certainly, we've gotten past that. It's actually a wonderful bonus for us. Avoid bandwagons. Avoid bandwagons. There's a thermal capsulorrhaphy was done a few years ago where people would have heat wand inside the shoulder, shrink the tissue, and that was a way of stabilizing it. Ultimately, we had a lot of ablated tissues, had more complications than we had benefits, and the problem was we knew that after the evidence came out 2 to 5 years after. And so you don't want to jump on bandwagons. Remember that your corporate rep is frequently biased. That doesn't mean that they can't help you and give you good evidence, but they're frequently biased. I use these guys as a screw. I actually still like to use their screw, but I actually kept breaking them. And I broke them because their screwdriver actually was titanium, was a soft metal and kind of bent and torqued. And they wouldn't admit it for a long period of time until finally I showed them two bent screwdrivers, and that was why their screws were failing. These guys actually argued that their technique was perfectly fine, until they actually had exposed that they had actually had 4 or 5 cases of people that had injured their arteries because this anterior to posterior screw was too over-penetrated and damaged some arteries. And so you have to be careful because they're biased. I get intraoperative images on all my patients, and I've had a surprising number of times where I've had to readjust a screw, readjust something to try to avoid complications. DVT prophylaxis, there's a debate between Europe And the United States, I'm not sure what you guys' routine is. Do you guys routinely use Coumadin perioperatively for a knee arthroscopy? Do you use anything?
No.
So I think that's commonly it's I do nothing, which is kind of the United States, or Europe says they need formal DVT prophylaxis. What do? I do aspirin and compression stockings, which is mechanical and chemoprophylaxis on everybody. Why? Those two things are really low risk, and I think that they reduce the risk of a potential DVT. Always have a postoperative plan, but you have to be careful of what those are. So regional nerve blocks for ACL reconstructions have been shown to actually slow rehabilitation and have some quad weakness, so for our athletes may not be the best idea. They can, also for upper extremity, if you do a block, you can't check your VD complications post-op if something was injured. You want no intra-articular lidocaine marking because we know it causes condylolysis. And then the last lesson is for all my surgical outcomes, and I've told this to patients forever, half the outcome is where I put the graft and how I fix it, or how I do the reconstruction or do the meniscus repair. Half is all of the rehabilitation. And that comes back to communication, so that the therapists know what the weak link is, so how fast they can rehab, but then their motivation for the athlete to get back to play.